All right, let's go ahead and move on to the next topic. We'll go to the different joints, and for this, try to remember the ligaments that will be called out and also some abbreviations that come with it, huh? Going for the jaw joint, this is the TMJ, temporomandibular joint. You will have the condylar, the hinge, and the plane joints in this case. The synovial cavity of the TMJ is made up of superior and inferior chambers. This would be right here, huh? TMJ, temporomandibular joint. If you look at it, this would be a lot of. If I could try to zoom it out, here we go. Right, so this is the capsule here, and you got your mandible, and you also have your fossa, right, mandibular fossa, for which this fits in. Now you see this condyle, this process, huh? This process now shows you a ligament tied there. This is your stylomandibular ligament. This is your styloid process. By the way, this opening here is your external acoustic meatus, huh? Now, this gives you an idea how the jawbone opens up, huh? This is the joint here, the TMJ. So when it opens up, it actually makes a good hinge joint here, right? And by way of that, it's able to open up wide. Now, there are clinical considerations here, especially if the edges of this joint are worn out. This can dislocate. Huh? Sometimes yawning would be an opportunity for this to dislocate. When you have a friend who's probably tired, does a yawn, and suddenly his jawbone is fixed, his mandible is fixed and won't return back. There's a good chance it was dislocated. Excessive laughter sometimes, huh? Anything that would open up this uh, mandible from the maxilla can also be a chance for this to dislocate. Now, the thing about it is, once it has dislocated, there's a good chance it can dislocate again. Huh? Here's a picture of the human remains, okay? And that's your TMJ area. And if you were to go deeper there, you would see it as this, okay? That's again your TMJ. This is a coronoid process of the mandible. That would be your zygomatic arch. And this would be your temporomandibular joint attached there, huh? There's an articular tubercle there to guide it in that position. So with that said, you see that actual disc for the TMJ. TMJ syndrome is one where you feel or hear clicking sounds in the jaw, especially if it's close to that left or right side. You can experience pain coming from the jaw down the neck, shoulders, and back. Sometimes this could be after waking up because your muscles in the jaw have relaxed and therefore have allowed some this movement or at least some changes. Now, facial pain can be felt, vertigo and tinnitus or tinnitus. Most of this is coming from malocclusion or misalignment of the teeth. There is a fixture that the dental practitioner can make you use, especially when you go to sleep. And this could also be ordered by your medical doctor. So, from all angles, you want to treat the psychological factor, do some physical therapy. Analgesics will come into play, especially in the beginning. And then, like I said, corrective dental appliance. TMJ, huh? TMJ syndrome. Let's go to the shoulder joint. This is also called the glenohumeral or humeroscapular joint. This is one of the most freely movable joint in the body. And what's the name again? What type of joint is this? All right. This is your ball and socket joint, huh? Ball and socket joint. It's supported by the biceps brachii tendon and rotator cuff muscles. Rotator cuff muscles are the supraspinatus, infraspinatus, teres minor, and subscapularis. As you see it from here, these ligaments hold uh, the upper extremity in place. You have the glenohumeral, coracohumeral, transverse humeral, and we'll locate that in the next picture. You'll also have some bursa or bursae, if it's plural, that will be found in this joint. So here you will see the acromion process of the scapula. You will see the head of the humerus and then the glenoid cavity. You will have the synovial cavity as well. Here you will see the supraspinatus tendon and the capsular ligament. The deltoid muscle is also here attached to the humerus, so it can provide some abduction when needed. Here's the head of the humerus fitted right into the glenoid cavity. See the many um, spongy appearance of the head of the humerus, right? And also that of the glenoid cavity. Because of this, they're able to tailor make, right, these bones to fit together. Shown here is the glenohumeral shoulder joint, and you see the bursae on both ends, many parts of it. You can see the ligaments. I have the acromion, and then I have the coracoid process of the scapula. Therefore, I'll call this the coracoacromial ligament. If I have the acromion and I have the clavicle, this becomes your acromioclavicular ligament. I have here the coracoid process. I have here the clavicle. So therefore, the ligament there will be named coracoclavicular ligament. So you see, it's easy to name the ligaments as long as you know which one uh, it connects together. And also, it's all make it a point to know where the ligaments are. For example, if we mentioned glenohumeral ligament, is it found in the pelvis, in the shoulder, in the foot, in the hand? The name itself, glenoid cavity, humeral, humerus. So it's in the shoulder joint. Okay? So you can also see the transverse humeral ligament here, which takes care of the biceps tendon, right? Which leads to the biceps muscle itself. If we take out the head of the humerus, you will expose the actual glenoid cavity there. Okay, and from that glenoid cavity, again, this is the scapula. The glenoid cavity is part of the scapula, right? If this is the coracoid process, this is the acromion. Acromion process is connected to the spine of the scapula, spine of the scapula. You will now have a space here above the spine, so we call it supraspinous fossa. But on that, you have the supraspinatus muscle. Here you see the tendon of the supraspinatus muscle. If this is the spine of the scapula, then this area below of the scapula is the infraspinous fossa. And the third is now you will see three muscles there. The supraspinatus muscle. I'm sorry, infraspinatus muscle, teres minor, and teres major. But you see here, the teres major is not part of the rotator cuff muscle. The teres minor is. And so you also see the infraspinatus muscle tendon showing there. So that's three now, supraspinatus, infraspinatus, teres minor, making up the three rotator cuff muscles. The fourth one is actually here in the subscapular fossa. That's where your subscapularis tendon comes out. Subscapularis tendon. All right. With the subscapularis tendon, you now have the four rotator cuff muscles: supraspinatus, infraspinatus, teres minor, and subscapularis muscle. Okay. In the human remains, you can see that nestled inside the glenoid cavity. This is anteriorly because I see the pectoralis major muscle. And if you take out the deltoid muscle, that exposes the head of the humerus inside the glenoid cavity. We have here the acromioclavicular joint. This is the clavicle. This is the short and long heads of the muscle here, of the biceps. Okay. Clinically, in this cavity, one that you can remember is shoulder dislocation. This is a downward displacement of the humerus, which is usually uh, present in, for example, sports activities. Basketball player laying up, and then an opponent guarding him falling or putting pressure on the shoulder joint. He comes down with one with that extremity lower than the other shoulder. You know that there's been some shoulder dislocation, right? Of all the rotator cuff muscles, the most that is clearly prone to the damage is the supraspinatus muscle of all the four rotator cuff. Shoulder dislocation can also happen when the arm is abducted and receives a blow from above, just like the player. Can also happen in fall injuries, and can also happen in children because of activities or falls that they. Shoulder dislocation, especially if there is a fracture involved, which is a spiral fracture, can be a clue for abuse. Another clinical medical legal application of that. Here's the glenohumeral ligament again, right, in the human remains, showing you the humerus and the scapula. On X-ray, they would look like this, huh? Okay. Here highlighted is the humerus on that same picture. And then you will see the shaft of the humerus. You see the surgical neck. And you also see the head of the humerus there. This is the greater tubercle. This is the intertubercular sulcus on the humerus. While we're here, let's highlight the rib, the first rib. Okay. And then you also see the acromioclavicular joint, clavicle and the acromion. This is the clavicle itself. And then you have the, again, the lesser tubercle. So it's amazing that we have samples of the x-ray so you can see your patient, right, after the fall injury. Is it just is it a muscle that got lacerated, or um, muscle that got injured, or is it a dislocation? This one here is not a dislocation. This is more of just an actual x-ray. Okay. In the human remains, again, another picture, the glenohumeral joint. Going deeper, we could see the capsule of the glenohumeral joint. Okay. And this other picture shows you the tendon of the long head of the biceps muscle. And this one shows you the clavicle also. All right. Here you can see the coracoid process of the scapula. And of course, this one here is your acromion process. If an injection is to be given, we palpate this acromion process, and about 3 or 4 finger breadths, you can insert or you can apply your IM injection, and you'll find it well placed in the belly of the deltoid, which is where we apply it or inject. Okay, we use the acromion process as um, a marker, a landmark, if you would, a marker of the human body, so we can apply the right IM injection. Here's another picture illustration where you see the scapula, glenoid cavity, spine of the scapula leading to the acromion. Above the fossa, above that, supraspinatus or supraspinous fossa, and that's where the supraspinatus muscle comes from. You have the infraspinatus muscle, and then you have the teres minor, and then you have the subscapularis. All right, your sits or rotator cuff muscles. Let's go to the elbow joint. It's a hinge joint and a pivot joint. Excuse me. As a hinge joint, you have the olecranon process getting into the olecranon fossa of the humerus. Remember that the olecranon fossa is part of the humerus, while the olecranon process is part of the ulna. Okay? You will have ligaments here. You have the lateral collateral ligament, radial, and ulnar, where ulnar is the medial collateral ligament. You see that in the picture here. You can see the olecranon process and the coronoid process here, almost looking like a monkey wrench grabbing on the distal head of the humerus. Where they land in is where the olecranon fossa is, and when it lands on the anterior side, you will have the coronoid fossa, okay, where the coronoid process fits in. This would make a hinge joint, huh? You can see uh, the collateral ligament, the ulnar, and on that side you will see the radiocollateral ligament. If you see the ulnar, it gives you an idea this is the medial side. On top of the head of the radius is the annular ligament. Anteriorly, you will see it with this, whatever the pointy part is, that's the medial side. And so this is the medial epicondyle, while this is the lateral epicondyle. We have a lot of bursa and ligament wrapping this very important joint. In fact, you have the radial collateral ligament here and the ulnar collateral ligament over there. Again, this is the tendon of the biceps, and this is the annular ligament protecting the head of the radius. So the thing here is that if you hear a ligament, you should be able to locate where it is. When you hear ulnar collateral ligament, that gives you an idea it's on the ulnar side, elbow. Radial, it would be on the lateral side, elbow. But if you have a name like annular ligament, it doesn't give you a clue. So for that, you gotta really remember where that ligament is. And again, add that to your notes. The annular ligament covers the radial head in the elbow joint. Okay, very important. Here's a picture of the elbow, right? With this radius, ulna, and humerus. Okay, and from superficial down to deep. Remember, these are features that you can see in your connect, the dissection process. Here you can see the ulna. Remember, the ulna is big proximally, big head proximally, and smaller head distally, while the radius is smaller head proximally and distal head is a little bit bigger. On the tips of both of this, you will have the styloid process, the small process there, Okay. Excuse me. Let's go to another joint, the same joint, but let's see if we could show, doesn't show here, but I just want to say that between the radius and the ulna, it creates another joint. You call this your pivot joint, Pivot joint. Again, this highlighted in this other shot is the radius, and the other bone is your ulna. Together they make the pivot joint, Pivot joint. All right. When you see these two bones crossing each other, that means it is on a pronated position because this will literally cross over the other bone, making an X. If it's looking like an X on the radiographic film, then it was a pronated position when it was taken. If they are parallel like what they are right now, then the hand is in a supine position. Okay, let's go to the hip joint. The hip joint will give you the head of the femur with the acetabulum, right? So with that said, this is also a ball and socket joint, ball and socket joint, which means it's very movable, freely movable. Interesting here is that at the tip of the head of the femur, you'll see a ligament. This is the round ligament. The round ligament has an artery in it, the round artery. In fact, if a trauma happens here and this head of the femur is dislocated, it may also tear or damage the round artery. If it's damaged, which supplies the head of the humerus may go into necrosis. And of course, that's another uh, disastrous injury. Okay? So picture this head of the femur fitting right into the acetabulum. And by the way, this joint can also wear down. In fact, this can also be replaced with prosthesis when it's time to replace them. They replace the whole head of the femur with a prosthesis, and then you could also replace this acetabulum. All right. Here we have some ligament, transverse acetabular ligament, and then we can see the obturator membrane. And of course, some other landmarks here are the ischial tuberosity, and then you also have your greater and lesser trochanter of the femur. Excuse me. This is the anterior part of the pelvic bone, and this is the posterior taken from the back, right? Just so for the anatomy of it, again, this is the pubis. This would be the ischium, and this would be the ilium. Okay, this would be the head of the femur into the acetabulum. This would be your sacrum, sacroiliac joint. At the back, you'll see more of the spine, telling you that it's more of the posterior part. All right, good. The hip joint has ligaments supporting it. We got the iliofemoral, pubofemoral, ischiofemoral ligament. When standing, these ligaments get twisted and making them tight. Right. Because of that, you will be able to make it firm. Right. And the muscles actually help to pull them in that direction, making the ligaments tight. Here's the head of the femur in this picture. And of course, a good X-ray shows us. Let me go into on this spot here, where you see the head of the femur. You have the iliac crest, the ischial tuberosity, of course, the greater trochanter of the femur, right? And you also see here the obturator foramina, both foramens, so foramina. You see the pubic symphysis, which is made out of what type of cartilage? Is it hyaline or fibrocartilage? Okay, it is fibrocartilage. Sacroiliac joint, and of course the sacrum. Here's another picture of it. I have the ilium or the pelvic bone and the femur. Right here you can see the pubofemoral ligament, meaning it's coming from the pubis and the femur. I have here the iliofemoral ligament coming from the ilium and the femur. And here you see the greater trochanter, the lesser trochanter. And of course, you will see the obturator foramen there. Over here, you have the lower part. This is the ischium. So if you have a ligament connecting with the femur, you have the ischiofemoral ligament. This is more of the back. Also, you see here the iliofemoral ligament, meaning it's connected to the ilium. All right, very good. In the human remains, you see this. All right, the femur, the coxal hip joint. And here you see again in the dissection, this is going to the deepest layer where you see the bones itself. Huh? Here you see the human remains where you see the femur and femoral head connecting to the acetabulum by way of that greater trochanter. Uh, no, this is, I mean, leading to the round ligament. The greater trochanter is not included in the acetabulum, but here you will see the round ligament at the tip of the head of the humerus. Again, it carries an arterial supply, huh? Supplying the head of the femur. Okay, well laid out here. All right, the hip joint can also be dislocated, but kind of rare. Some infants can have congenital dislocation, and for that, we'll have to put the baby in a harness, all right, to have it mature and become more stable. All right, let's go to the knee joint. The knee joint is also called tibiofemoral. See, the femur, the distal end of the femur makes up the knee joint. So it's involving the femur and the tibia. Right? This is the largest and most complex diarthrosis of the body. And this is a major hinge joint, huh? Hinge joint. It's also called, there's also a joint here, patellofemoral joint, which involves the patella this time. So here's a picture of it. This is the anterior view of it. This is the femur. This is the tibia. Right? You will see the condyles are articulating parts of the bone. Now, if this is the tibia, on the lateral side, you will see the fibula. This is the tendon of the patella. We took out the patella so you can see the inside. And very important here are the ligaments. You have the medial collateral ligament, right? And you have the lateral, right? Lateral ligament. And inside you have your X formation where you have the ACL, anterior cruciate ligament, and then going backwards you have the posterior cruciate ligament, or PCL, anterior cruciate ligament, posterior cruciate ligament. Looking at it at the back, you can still see the anterior cruciate ligament, and you can also see the posterior cruciate ligament. This helps to keep the joints in place. If you take this out, you will see on top of the tibia a plateau-like formation, right? And you'll see right away your meniscus. So the bone of the tibia of the femur meets these part of the tibia, and the weight is put on the mesa of the what we call the mesa, or the tabletop, if you would, or the top part of the tibia. If a person has jumped from a high place and landed on his two legs, it would be a perfect land, but sometimes he will suffer from a fracture. You may not catch this fracture on an AP or lateral view. You need to put this fracture in a settegast, or a position where both knees are exposed, and you will see the fracture coming from here, on top of it. And you call that your plateau fracture, your plateau fracture. Plateau, meaning like the top of maybe a short hill. Plateau fracture, huh? All right. The knee itself, when the leg is straight, is already in an extended position. And when it bends, it goes into flexion. Huh? This is a major hinge joint. The knee, when you're standing up, is stabilized by the quadriceps muscle in front, the tendons of the semimembranosus muscle at the back of the thigh, and the lateral meniscus and medial meniscus. Together, they absorb shock and prevent side-to-side rocking and are controlled by the transverse ligament. Okay? The knee, right, is also termed as the popliteal region. And of course, you got the fibular collateral ligament and the tibial or medial collateral ligament holding it steady. There will be intercapsular ligaments, which keeps the capsule in one place. Right? We call that your intracapsular ligament. The CL and the PCL would make an X, like we saw. Very important you know what the function of this. ACL prevents hyperextension of the knee when the ACL is pulled tight. So from a flexion, the knee joint will stand up, will make you stand up, and it will be in a extension, right? Now, it should not go into hyperextension because it's not anatomically designed to do that. However, if you have an athlete, a football player maybe, and someone grabs his leg, right, and someone pushes him forward, you will create a hyperextension. And this will rip this ACL, right? The force is too strong, it will rip the joint and put it in a hyperextension, which is really, really painful. The PCL, posterior cruciate ligament, coming from the back, prevents femur from sliding off the edge of the tibia. That can also happen. So by that, you protect it from dislocating. All right, here's another picture of the joints, of the knee joint. You can see the PCL and ACL, which is also seen from here. All right. Again, this can get damaged or lacerated or torn and result in the injuries that we mentioned a while ago. The knee joint has a lot of bursae, and this helps stabilize the knee joint as itself, right? And it will also have areas or bursae in the popliteal region. The ability to lock and unlock the knees is important when you are standing on both legs. What happens is when the knee is fully extended, your ACL allows locking. It does lock. In fact, your ACL is the one who's keen about that. When the knee is fully extended, the ACL allows locking. The femur rotates medially on the tibia. Remember that. The femur rotates medially on the tibia. By doing so, the knee ligaments get tight and therefore allows more stability. Now, to get in this sort of lock, you need the uh, popliteus muscle to go in the opposite direction to unlock this. So every time you stand up and be on your two legs, then you're actually locking or tightening the ligaments. And to unlock that, you're actually using your popliteus muscle. Okay. Here's a picture of the knee joint. You can see the condyles or the articulating parts. They brought down the patella and the patellar ligament so you can see it clearly. Right there, you can see the anterior cruciate ligaments from this human remains. And a little bit, I know it's not best seen, the PCL here. Maybe it could be another picture. But you see here right away the ligaments and the bursa is needed in the knee joint. Here's another event. Like I said, someone holding on the leg, or it get trapped against the ground, and then someone else goes on top of him. This will end up in a twist. And depending on the angle, it end up in longitudinal damage here. You can see the ACL being torn right there. And again, this is very mainstream in sports nowadays, especially with ground sports. We We could use arthroscopy, where scopy means viewing into the joint, arthroscopy, and see what the damage, the extent of the damage is. You can also do surgery procedures through this arthroscope because there's less of tissue being um, opened up in front. The healing is faster and recovery is more quicker. Huh? All right. But it takes a lot of expertise to properly align them and make them heal. Here's a picture of an MRI of the knee joint, okay, with the femur on top of the tibia, and those are our muscles there. Here's another X-ray of the knee joint, where you see the tibia, a little bit of the fibula at the back, and then you have the tibia on top, top of the distal part of the femur. Okay, let's see if I have some pictures here. There's a lot of these pictures. If you go to your book, right? This is the fibular collateral ligament. Again, is it ulna or media? It is ulnar, right? Ulnar ligament there, collateral. You can also see the ACL here, okay, shown there to highlight it. Also at the back. You can also see the transverse ligament. Here you will see the posterior cruciate ligament. Okay. This shows you the median epicondyle, and you have the lateral epicondyle above the condyle. You got some articular surface of the femur, adductor tubercle, right? Then you have your medial condyle and the lateral condyle of the femur. Also, you have the medial condyle of the tibia, lateral condyle of the tibia. Then you have the patella here highlighted. Okay, how about let's highlight the femur so you get visually uh, capable there, right away identifying bones. See, like I said, when the X-ray comes in, we should be ready to identify the bones involved. You see here your fibula. Okay, if you see the fibula, keep in mind it's a lateral bone, so all anywhere in this side is lateral. Okay, the tibia is more medial, so anything you see here based on this side is more medially located. All right. Let's go to the ankle joint. This is known as the talocrural joint, talocrural joint. But take note that this joint has connections. The medial joint is between the tibia and the talus, while the lateral is between the fibula and the talus. The talus actually is a tarsal bone found just beneath the uh, malleolus, just beneath the tibial, with the malleolus head on that side. So this is your talus. Now take note, the outer lateral part of the ankle is called the lateral malleolus, and it's part of the fibula, while the medial part of the ankle is called it's called the medial part is called malleolus, medial malleolus. So that shows you that the malleoli, or malleolus for one singular, medial and lateral are located in two different bones. The medial malleolus is on the tibia, while the lateral malleolus is on the fibula. I remember that. That's a favorite question in the boards, and they will try to confuse you. Okay, so Same thing with our knowledge here. We have the other tarsal bones. We mentioned the talus. We also have here the calcaneus. And then you see this being on the lateral, you'll see this as your cuboid. And the three bones are the medial cuneiform, intermediate, and lateral cuneiform. Huh? You see them in this fashion as well. Okay. But this is your medial cuneiform. This is your navicular, and this is your talus, not seen much. And of course, at the back would be your calcaneus. So remember, the ventral group, or let me say it again, the proximal group of tarsal bones, easy to remember. You get the talus, the navicular, and then you also have the calcaneus, which is the heel bone there. Okay, the distal part or distal tarsal bones are the three cuneiforms, medial, intermediate, and lateral cuneiforms, and then add uh, the cuboid bone to the distal row of tarsal bones. Okay, here's a good picture of it. You see the talus, you see the calcaneus below, and here's a picture above. You see the cuboid, and see the picture of it also on from the bottom. Okay, and then you have the navicular. Then we have the cuneiforms, your medial cuneiform, intermediate, and your lateral cuneiform. And then finally your cuboid. I'll let you look at that for a few. All right. On this part of the calcaneus, a tendon is attached. It's the Achilles tendon, and that's attached to the gastrocnemius muscle. Greek mythology tells us that Achilles, who is a demigod, son of a human and a god, was dipped into a sacred river, but he was held at the ankles, and therefore this one did not get dipped. So the legend goes that he is uh, hard to defeat, huh? But he only got defeated when an arrow hit that ankle joint. So that joint, or that area, is called Achilles tendon. So when you say my Achilles tendon is this, that means it's your weakness. What is your weakness? That's your Achilles tendon. Or, uh, which means if your weakness is you can't dance, then you can say my Achilles tendon is I can't dance. So just to let you know why it's used that way. All right, here's another picture of the talus, right? Right beneath the tibia and connected to the calcaneus. Here you see also the navicular. Okay, navicular. From the top, you see the talus. This is the navicular. This is the medial cuneiform. This is the intermediate cuneiform. This is the lateral cuneiform. This is the cuboid. All right. This is the fibula, which makes this the lateral malleolus. This is the tibia, which makes this the medial malleolus. The calcaneus is not seen in this view. This other view shows the calcaneus. See? All right. All right. This is inflammation of the joints. Okay. Most common crippling disease in the U.S. And then you also have the osteoarthritis. Like we said, it is inflammation of the bone and the joints. It's a wear and tear type of arthritis. Right? The cartilage softens and degenerates, and spurs can develop. Another condition is what we call rheumatoid arthritis. In the rheumatoid arthritis, your own immune cells mistake your joints for foreign and they attack it. So you have an autoimmune condition here. Antibodies um, attack the synovial membrane. Okay, and this will be rheumatoid arthritis. Compared with OA, OA is abbreviation of osteoarthritis. Compare RA, which is rheumatoid arthritis, to OA. Excuse me. The OA is wear and tear in etiology, while RA is more autoimmune based. Another comparison is OA is more in the later years because of the wear and tear that still has to happen. While RA usually doesn't pick any age. It can happen in the young, it can happen in the elderly, midlife, just whenever you have an inflammation caused by the antibodies. Okay. Another probably distinction is OA is usually on the weight-bearing joints, and RA sometimes can may not be found in the weight-bearing. You can see that in your hand. See, ankylosis is another condition where the vertebra fuse together, And this would be difficult because imagine the vertebra fuse, that means your movement is limited. And on top of that, it will produce some pain. Remissions occur, steroids and aspirin control help up with the inflammation. Repair of the joint, where plasty is repair and Y is pertaining to. So, repair of the joint we call arthroplasty. Replacement of diseased joints with artificial device called prosthesis. Okay, here's a picture of arthritis. Okay, and look how deformed it is. You have the distal or the proximal interphalangeal joints fully inflamed. Some of them are not even aligned with the actual uh, bones. Like look at this. This is right. This is proximal interphalangeal joint. But look, it's the middle is no longer in alignment with the proximal phalanx. And look at all the hot spots there, inflaming. look at the metacarpal and the matching phalanx, right, superior phalanx, they're not even on top of each other, right? So all this is because of inflammation, and your immune cells mistake these areas and hit on it. So that's why it's called autoimmune disease, huh? Right. Of course, this will not only cause chronic inflammation, but when they heal, it may leave the joints in that actually deformed pattern. And therefore, activities of daily living, ADL, activities of daily living, movement is limited. And like I said, ADL is also limited. For replacements, here are some prostheses. You can have the knee joint replaced. This is the patella, but this will be the condyle area of the femur, and this would be the receiving area of the head of the tibia. This is knee joint, huh? Here's another picture of a knee joint prosthesis. You have the actual condyles, and this will be attached inside the femur, while this shows you uh, the meniscus on top of the tibia. Another thing is, in due time, this can wear out. Huh? This can wear out. Take an X-ray after 10 years, you'll find this may be just a thin plate. This was shaved off, if you would, but they will be scattered all around the synovium. Sometimes it can produce some uh, problems. This one is the replacement for the pelvic joint, huh? Right? The pelvic joint will have this replacing the acetabulum, right, connected with the pelvic bone, and this will be attached or embedded in the femoral head. So now you have a replacement of the acetabulum and the femoral head, right? RTs, you will be asked to take pictures several times, huh? And I mean, in many cases, we need to take an X-ray of that because we want to make sure it fit properly and it sits properly there. Okay. All right. Those are the joint prostheses. And that ends the lecture for this chapter, chapter 9. Okay. Let's throw some quick questions. All right. Quick question is, where do you find the iliofemoral ligament? Is it on the shoulder joint, the pelvic joint, or the knee joint? Iliofemoral ligament is found, all right, found in the pelvic joint. Okay. How about your gleno? Found again, shoulder joint, huh? How about your annular ligament? Is it in the shoulder joint, the elbow joint, or the knee joint? Okay, it is found in the elbow joint. All right. True or false, the transverse ligament is found in the knee joint. True or false, transverse ligament found in the knee joint is true. True or false, the ACL prevents the femur from sliding off the tibia. The ACL prevents part of the femur from sliding off the tibia. It is false. Huh? ACL prevents hyperextension. PCL prevents sliding off. What is the muscle that releases us when the knee joint is tight? What is the muscle that releases the tightness of the ligaments when we are ready to flex the knee? Popliteus muscle. Okay. What are the four rotator cuff muscles? Four rotator cuff muscles you have. All right, it's supraspinatus, infraspinatus, teres major, and subscapularis. Again, supraspinatus, infraspinatus, teres major, and subscapularis. All right, good. Now, what uh, what is the condition when there is pain in the jaw, right, radiating towards the neck area also, huh? And can be dislocated. Condition is TMJ syndrome, huh? TMJ syndrome, right? What is the condition um, in the? That's a good point there. Let me rephrase the question. Where do you find the lateral malleolus? Is it on the tibia or the fibula? Where do you find the lateral malleolus? Is it on the tibia or the fibula? Okay, it is found on the fibula. Okay, all right, very good. Next question is, where do you find, okay, the joint between carpal bones is called what joint? Okay, is it condylar or plane joint? Right, the joint between carpal bones is condylar or plane joint? All right, plane joint, huh? The joint in the between the radius and the ulna, is it pivot or hinge joint? Between the radius and the ulna, is it pivot or hinge joint? It is pivot joint, huh? All right, the joint between the metacarpal and the phalanges is called what? Phalangeal joint? No, no, no. Let me rephrase it. The joint between the metacarpal and the phalanges is hinge joint or condylar joint. Hinge joint or condylar joint. It is condylar. Okay. A joint between the humerus and the ulna is hinge joint or pivot joint. Hinge joint or pivot joint. Yes, it is a hinge joint. Okay, all right. Last question. The olecranon fossa is found on the ulna or the humerus? Ulna or the humerus? All right. It is found on the humerus. Okay. I have a makeup point if you're interested. Okay. I want you to, and this is honesty principle, I want you to practice your range of motion. Okay. Do your flexion, do your extension. Okay. And do your hyperextension. Go through it again. And if you have done it and practiced it, I want you to email me and tell me your favorite range of motion uh, procedure or process. You can say, hey, Dr. Vad, my favorite is hyperextension of the carpal, of the wrist joint. Okay. That means you have watched this video and, you know, that's your credit. Okay. I might put some points there for the upcoming week lab, huh? All right, good. So uh, let me know, and then I'll go from there. It's also a check for the ones who actually watch the video, huh? The video lectures. All right, from here you can go to your Connect and look at the dissections, okay? And also watch for the questions in Connect as well. Tomorrow's Wednesday. We have our lecture on the muscles, huh? Chapter 10. And from there, we will have a lecture on So tomorrow is the anatomy of it, and then you will have the physiology of it in chapter 11. Very interesting topics, huh? And then at the end, we will have the advanced lecture for chapter 17, huh? On Friday. And this is all about uh, endocrine system. Okay? All right. Study well. We're almost there, okay? And I'll see you tomorrow. Thank you.